evening, everyone. I'm Majinkya from Marketing Department. Welcomes you all to the forum of Coffee Over Critical Cases through by Pollen Healthcare Private Limited. It gives me a great pleasure to introduce our esteemed speaker for today's session, Dr. Chandrashish Chakravarty. Dr. Chakravarty is a senior consultant in respiratory and critical care at Manipal Hospital, Kolkata, with over 14 years of rich clinical experience. He is an alumni of Calcutta Medical College and completed his MD from AIMS, New Delhi, securing All India rank of 10. He holds several prestigious international qualifications, including MRCP from UK, FRCP from Edinburgh, EDIC, EDRM, and FCCM, and has completed advanced fellowship training in critical care at University of Miami, USA. Dr. Chakravarty has an extensive expertise in managing critically ill patients, including ARDS, sepsis, ECMO, and advanced respiratory care. And it has is also an examiner for MRCP, IDCCM, and Dr. NB Critical Care. He is a regular faculty at national and international conferences, a recipient of ESCM Young Lecturer Award, and currently serving as a scientific committee member of ISSC West Bengal chapter. We are honored to have Dr. Chakravarty with us today, and I would like to request Dr. Chakravarty to take the forum and continue with his presentation.
Thank you very much. Hope I'm audible. So today we'll be discussing on the role of Sulbactam and what is Sulbactam and how is it used and how it should be used is the topic of discussion today. So I would request
Sir, you're sounding feeble actually. The sound is very less.
Can you hear the sound now?
Okay. It would be great, sir, if you could kindly be a bit more clear.
Am I audible now?
Yes, sir.
Okay. Okay. So can you please change the slide? So the evolving role of Sulbactam in managing MDR Acinetobacter, an evidence-based review. Next slide, please. So as you know that multi-drug resistant Acinetobacter baumannii is a critical threat with limited and often toxic therapeutic options. As rightly said that this Acinetobacter is a successful nosocomial pathogen with a remarkable propensity to rapidly acquire resistance to multiple antibiotic classes, and they're often multi-drug resistant or extremely drug resistant. It is more successful in parts of the world where there is humidity and there is heat, like India, Greece, certain parts of Rome, African countries, etc. And it is most of the time it colonizes various surfaces and can act as very dangerous nosocomial pathogen, particularly causing hospital-acquired pneumonia and hospital-acquired bloodstream infection. Bloodstream infection from Acinetobacter is particularly associated with a very high mortality, and there is a pathogen specific or attributable mortality in case Acinetobacter is isolated from blood, which is carbapenem resistant. So we need to be very careful in treating these patients. I have particularly found some strange manifestations of Acinetobacter bloodstream infection. Firstly, they are very difficult to treat because most of the time you are left with very few options like polymyxin B, aminocycline, and sulbactam. And you all know that polymyxins are nephrotoxic. Not only that, these kind of patients become hemodynamically unstable, and sometimes they have refractory fever, which does not respond quickly. So the clinician's dilemma remains that whether to start polymyxins in all patients with Acinetobacter, or we can use something else. Sometimes you, like in case of bloodstream infections and very severe infections, you probably don't have much option except to use polymyxins with some other combinations. But sulbactam is a very good option if the patient is suffering from Acinetobacter infection, particularly of the lungs, where you have maybe some other antibiotic like minocycline, which is also sensitive, and you can give a high dose sulbactam and minocycline combinations to treat such infections and avoid polymyxins. Next slide. So what is a sulbactam? So sulbactam is basically a beta-lactamase inhibitor belonging to the penicillinic acid sulfone class. It has got a dual role. The classical role is basically it inhibits beta-lactamases and thereby protecting partner beta-lactam antibiotics. So it has been combined with antibiotics like ampicillin or cefoperazone. And it has got an irreversible inhibitor of beta-lactamase enzyme designed to protect partner antibiotics. But it also has got independent antibacterial activity because key penicillin binding proteins in Acinetobacter, particularly PBP1AB and PBP3, and this binding disrupts cell wall synthesis, leading to direct bactericidal effects independent of its beta-lactamase inhibition. So beta-lactamase inhibition is basically an irreversible binding of serine beta-lactamases, which protects the partner drugs from enzymatic degradation. It is effective against class A beta-lactamase like TEM and SHV and some class C enzymes. But it is usually not effective against carbapenemase, partially effective against ESBLs, and it's also not effective against metallo-beta-lactamases. The direct antibacterial activity, as I mentioned, is particularly against Acinetobacter, giving intrinsic bactericidal activity. So it covers Acinetobacter, which is unique, dose dependent. It has some activity against Haemophilus influenzae, Moraxella, Neisseria, and some entobacterials when combined with antibiotics like cefoperazone or ampicillin. It can cover for some gram-positives with partner drugs like ampicillin, for example, Staphylococcus, Streptococcus, and has got some anaerobic activity against Bacteroides fragilis or oral anaerobes. The most common combination is ampi-sulbactam, which can be used in community-acquired infections. And this is the first-line drug that has been mentioned against Acinetobacter in the Western guidelines to use ampi-sulbactam because in their country, isolated sulbactam is not available. However, we'll come to it that the dose of sulbactam required for Acinetobacter infection is much high, and that for that you have to give a very high dose of ampicillin, which may be required. Cefosal is widely used in India and has got a strong gram-negative coverage, particularly for biliary infections. There is a newer drug which has come up, which is called the sulbactam darlobactam, and it is particularly designed for CRAB, that is carbapenem-resistant Acinetobacter, Darlobactam protects sulbactam from OXA enzymes. It is FDA approved and will probably be available in India soon. So the chief and the most important use of sulbactam remains in ventilator-associated pneumonia due to Acinetobacter, bloodstream infections from Acinetobacter, intra-abdominal sepsis, and post-surgical or wound infections from Acinetobacter. So these are the 4 areas in which you mostly use sulbactam. Now, next slide, please. So laboratory studies have confirmed that sulbactam works synergistically with colistin and carbapenems, and particularly with polymyxin, the synergy is very high. Next slide. Sulbactam pharmacodynamically works with a time above MIC model, where the drug concentration should remain above the MIC for the maximum duration of time. And for severe infections, a target of more than 60% of the time above MIC is often required. So for this, the sulbactam should be given 3 grams every 8 hours, infused over at least 4 hours, which achieves a more than 95% probability of target attainment, as you can see in the cartoon on the other side. So I think it's very clear that, as I was mentioning before, that the target dose of sulbactam is 6 to 9 grams, or some people will now say 9 to 12 grams actually. And so if you're using actually ampicillbactam, you are giving 2 grams of ampicillin and 1 gram of sulbactam. So even if you give 3 grams 6 hourly, you will be giving only 4 grams of sulbactam, which is not sufficient. And the same is with cefosulbactam. So unless the bacteria or the Acinetobacter is sensitive to cefoperazone, it doesn't make sense to give cefosulbactam or ampicillbactam alone, but it makes much sense to give isolated sulbactam at a dose of 9 to 12 grams. Next slide. So this is a meta-analysis of 12 trials which confirm that high-dose sulbactam is clinically superior to alternative therapies. And overall findings, when all sulbactam doses were pooled, there was no significant difference in clinical response compared to control therapies. But the crucial subgroup was basically the group with a high-dose subgroup, that is those who received more than 9 grams of sulbactam, 9 to 12 grams of sulbactam. And these show a statistically significant advantage in clinical response. Next slide. So high-dose sulbactam plus other agents like tigecycline, minocycline, polymyxins has now come up as the #1 choice. Polymyxin and monotherapy is usually not advocated except for few situations like CNS infections or urinary tract infections, where sulbactam does not penetrate the CNS. And polymyxin with carbapenems, again, is not a great therapy because the MIC of carbapenems in case of Acinetobacter infection is so high that it's kind of impossible to achieve those target levels with carbapenem dosing. Next slide. So safety profile and nephrotoxicity, obviously, sulbactam is not nephrotoxic, and colistin with high dose sulbactam is associated with significant less nephrotoxicity than other colistin combinations. And the strategies to overcome resistance, one we have already mentioned, is to give high dose sulbactam. The second is to use combination therapies. And third is to use newer inhibitors like darlobactam. Now, why sulbactam may fail? Sulbactam may fail because of OXA-type carbapenemases in Acinetobacter, PBP mutations, and efflux pumps. So this is important to know that where are the areas where it can fail. It is a generally well-tolerated drug. There's not much of safety issues. It can cause some GI upset, some injection site pains. Rarely, when combined with cefoperazone, it can cause some hepatotoxicities. It can cause some cytopenias. Particularly, you should be careful starting sulbactam in patients where there is low platelet counts. And if you are starting it, you should follow it. It may cause C. diff infection, so you might have to stop. And in case of combination with cefoperazone, it can cause some amount of coagulopathy, but not alone. Next slide. So the evidence provides a clear pathway from scientific rationale to clinical superiority. The challenge is to treat MDR Acinetobacter. The rationale is to use intrinsic PBP activity and in vitro synergy of sulbactam. The method is to give high dose sulbactam and extended infusion, which is PKPD optimized, as we have mentioned. And the proof is there is superior clinical cure and improved safety as verified by the meta-analysis. So in case you are treating CRAB, particularly in the lungs, in soft tissue infections, in blood, or intra-abdominal sepsis, sulbactam most of the time is a mandatory addition to whatever other drug you are using to treat Acinetobacter. But sulbactam should not be used alone to treat Acinetobacter. There should be some other antibiotic which you're using along with it. Next slide. So it should be a primary agent, and now sulbactam based therapy has become the, I should say, it is the main workhorse of treating CRAB, the cornerstone of therapy, particularly in the Western guidelines. And we should utilize it as an effective colistin sparing strategy to reduce the risk of nephrotoxicity, and always use in combination with another active agent, particularly tigecycline or minocycline or cefoperazone if it is sensitive. Carbapenems, if you find it sensitive. In my hospital, we rarely have carbapenem sensitive Acinetobacter. And the key advantage is well-established safety profile, even at high doses required for the efficacy. It is renally excreted, so you might have to adjust for renal insufficiency. Next slide. Achieving optimal outcomes requires aggressive and optimized dosing strategy. We have already targeted sulbactam dose. I will not say 6 to 9 grams. I will say 9 to 12 grams is the dose. If you have reduced the dose to 6 grams, you might have to in case of renal impairment. Recommended administration is extended infusion of at least 4 hours. And dosage must be adjusted for patients with renal impairments, rationale. And as we already mentioned before, it is colistin sparing strategy. Next slide. I think we've already discussed about it, about the role of sulbactam in bactericidal activity, aggressive dosing, and the evidence. Next slide. Next slide, please.
So this was the final slide for your presentation, sir.
Okay. So thank you
Yeah.
very much. If there are any questions on Sulbactam or treatment of Acinetobacter, I'll be happy to answer that.
Yes.
Any questions on Acinetobacter or Sulbactam? I'll be happy to answer. So
The
just a
forum.
little bit
Yes.
about, just before anybody asks me question, just an outline about how to deal with Acinetobacter infections in general. So in case it's a bloodstream infection, I think polymyxin should be added because it's too risky to treat Acinetobacter in blood without polymyxins. And the reason is because it has got a very high attributable mortality. If it is in the urine, you can use colistin monotherapy. Don't use polymyxin B because it does not concentrate in urine. Neither does tigecycline or minocycline. If it is in lungs, the first choice is to give minocycline and Sulbactam guide therapy. If it is in the abdomen, you can use tigecycline plus Sulbactam. If it is in the soft tissues, you can use tigecycline plus Sulbactam. And if it is in the brain, then it is usually colistin intrathecal and polymyxin B IV, both of them. Rarely, if it's a bad VAP and you don't have any other option except colistin sensitivity, then I will suggest to give polymyxin Sulbactam high dose, polymyxin B high dose, and colistin inhalational therapy. So that's my kind of the flow chart for treating Acinetobacter. If there's any other questions, I'm happy to answer.
So team, the forum is open for the questions. If you have any doubt or any question regarding Sulbapol, Dr. Chandrashish Chakravarty will be happy to help us.
Hello, I'm Ganesh from Hyderabad. Hope I'm audible.
Yeah, hi.
Yeah, hi. So good evening. It's an excellent session. I really enjoyed it. And my one question is that this carbapenem resistant Acinetobacter bomb is very difficult to treat, being a very high infection. So in this, the combination what you suggested with Sulbactam. So I have gone through this IDSA new article also, which shows that the role of Sulbactam to be combined with the Sulbactam in treating. Do you have any such experiences from your side?
Role of what should be combined, sorry?
Avibactam.
Avibactam.
Along with the Sulbactam plus maybe some other combination therapies like ampicillin or some other combinations. So there is a new article which I have seen that it has given a promising results when you combine with Avibactam also.
No, actually, I don't have that knowledge of combining Avibactam and Sulbactam. There is combination of Sulbactam with some other anti-Acinetobacter antibiotic, like as I mentioned before, maybe minocycline, maybe polymyxin, maybe tigecycline, maybe cefiderocol. Cefiderocol also has anti-Acinetobacter activities, but I have not read about any Avibactam and Sulbactam.
Okay, it has recently come out actually, so I have gone through that.
Okay.
Yeah. Thank you. Yeah.
Any other questions somebody would like to ask? Okay, so I guess there are no further questions. And I'd like to thank Dr. Chandrashish Chakravarty to giving a glimpse and showing us the flow of role of some Sulbactam in Acinetobacter bowman infections. So it was very informative and helpful session for all of us, and would like to re-encourage another sessions similar to with